Hi, my name is James Katsilometes. I'm a Master's of Public Health as well as medical student at Pacific Northwest University. I'd like to thank GARD for having me today, and I am talking about the reappropriation of validated treatments in emergent times, high-titer convalescent plasma in a rural setting with the help of rapid diagnostics. Brief history on immunological treatment. It's documented use since the 1900s. Emil von Behring and Katsilometes Shibarisabu are the first scientists credited for experimental findings in artificial passive immunity. They essentially were the first to take an animal, in this case a rabbit, administer diphtheria toxin. This was the first example of a vaccine. They then drew serum from the rabbit and injected it into another rabbit. They then took virulent diphtheria toxin and injected it into that rabbit as well as a rabbit that did not receive the serum. And they demonstrated protective substances within the serum. And this was the first demonstration of passive immunity. Von Behring went on to actually win the first Nobel Peace Prize in Physiology in 1901 when he demonstrated that diphtheria serum from a horse could be used to treat humans with diphtheria. So where does convalescent plasma come in? So in that previous experiment, they were injecting serum, where we now use plasma. The only difference between plasma and serum is that serum has white blood cells as well as platelets, and plasma does not. Blood is made of three parts: red blood cells, white blood cells, and platelets, and then the plasma. Today we hook a person up to an apheresis machine which draws out the whole blood and then separates out the plasma, and the white blood cells, platelets, and red blood cells go back into the donor. That plasma is then injected into a sick patient, and with hopes of using their antibodies as a protective measure against whatever illness is of concern. This has been used in several different diseases throughout the century: pertussis, Ebola, scarlet fever, influenza, and then today, currently COVID. The only difference between convalescent plasma and regular plasma is that convalescent plasma is drawn in the convalescent stage of the immunological response, which is when there are no signs and symptoms. If you look at the graph to the bottom right, it demonstrates this. So early on in the pandemic, evidence started coming out of China to see if we were throwing everything at this disease. Looking at the medical community was looking to see any ways we could combat the disease. One of these going back to convalescent plasma. They took, this was a randomized control trial published in JAMA of June 2020. It looked at 28-day improvements. Improvements were defined as a 6-point disease severity scale or discharge from the hospital. And severe patients were defined as those with respiratory distress or hypoxemia. And life-threatening were those requiring mechanical ventilation, were in shock or multi-system failure. And what does the data show? The data shows that those suffering from the severe disease showed significant improvement when they received convalescent plasma compared to those who did not. Those who were already suffering from life-threatening disease did not demonstrate difference, and when you combine the two, there was also no difference. So as more evidence was coming out on the efficacy of convalescent plasma, the scientific community wanted to know, does the amount of antibodies within the plasma demonstrate better outcomes? So we all have different immunological response, especially to SARS-CoV-2. And with that being said, we generate different numbers of antibodies. This is measured using titers and detection with an immunoassay. The Journal of Clinical Investigation published an article in December 2020 looking at the types of patients that generate the highest number of antibodies or generate the best immune response. And what did they find? They found that patients who donate plasma more on a shorter time length within their convalescent stage demonstrated higher numbers of antibodies. Other correlations were older age, males, and those with severity of symptoms, those with fever especially and difficulty breathing, also demonstrated higher levels of plasma, of antibodies, excuse me. So the first big paper that came out demonstrating or looking at whether titer made a difference was this, published in the New England Journal of Medicine. It's a retrospective cohort study published March 2021. It looked at patients receiving higher titers if they had better outcomes, and they did not show better outcomes in those with higher severity, much like the same coming out from China. However, patients not receiving mechanical ventilation that were hospitalized did show significant improvements when receiving high convalescent plasma as opposed to those receiving low. So we're here in a rural setting in Arizona, and we wanted to know, is this data applicable to us? So here's a map from the New England Journal of Medicine paper that I just discussed, and the locations where they received data from. There's Kingman, Arizona with that star. Here's the U.S. Census data, once again, Kingman with the star. And if you compare these notes or these maps, you'll notice that there's higher population density in the areas where they tested this high convalescent plasma. So it was highly sampled from regions with greater populations and regional medical centers or academic medical centers. So we want to take a look at the question, does this apply to us, as this does not demonstrate us here in Arizona or much of rural America. So here's our study design. We ran a retrospective cohort study. We had patients who, it included patients who were admitted to our hospital with COVID-19 receiving standard of care and convalescent plasma. We had 31 patients that received the high titer convalescent plasma. They were matched with patients who had just received unlabeled convalescent plasma. And then we looked at outcomes, that being 28-day survival, 28-day readmission, 28-day ICU admission, number of days spent in the ICU, and number of days spent in the hospital. Little breakdown of our demographics. We had 14 males and 17 females. They were matched to 14 males and 17 females of the low titer group. Age distribution, you can see that our medians are very similar here, as well as our interquartile ranges. We did the best we could. Same with the males here. Here's the breakdown of race. As you can see, very high Caucasian population in our area as well. We did our best once again to match for race. We also matched for comorbidities. This was based on peer-reviewed articles. We chose obesity, hypertension, chronic kidney disease, COPD, and diabetes, as well as cardiovascular disease to attempt to match as far as comorbidities go among the two populations. So now let's take a peek at our outcomes. Our 28-day mortality rate was almost double that in those receiving low titer as those compared to high. Furthermore, 28-day readmission was 4 times that in those who received low convalescent plasma as compared to high. And lastly, those admitted to the ICU, there were over twice as many once again. So what does this say on the impact in a rural hospital setting? We looked at average length of stay, and What do you know? Those receiving high convalescent plasma were here significantly less amount of days. These reduction of days are even more relevant to an underserved, under-resourced setting, and we find this to be very significant. The conclusion is the administration of high convalescent plasma appears to be more effective in improving outcomes of hospitalized patients with SARS-CoV-2 in a rural hospital setting than does a lower convalescent plasma. So, with the use of rapid diagnostics, future outbreaks, epidemics, pandemics alike can be managed with the reappropriation of validated treatments like high-titer convalescent plasma in a rural setting. Thank you for your time today. Here are some of my acknowledgments.